Hi again, I'm Bob Wilford, working with the Family Medicine Clerkship students. And in this video, we're going to talk about the abdominal examination in a video visit. Just like other parts of the physical examination, it's the history which really guides what we do. This was true when we consider thinking about the cardiopulmonary systems, the integumentary system, a person's psychiatric problems. It all comes back to the words they used to describe what it is that prompted them to contact us in the first place. Many of us come to think while we're learning in the basic and advanced doctoring courses that the physical examination is going to be dispositive, that will generate a list of possibilities as we're listening to patients talk, and that the physical examination is that which will help us pick amongst that list. In fact, that's not the case. Instead, we should have an idea what the patient already has based solely on their report of symptoms, and really be using the physical examination only to confirm our suspicions. One of the perks of working from home during the COVID crisis is that one's colleagues are rather more malleable to participating in projects like a little video than they might have been at the office. I think that when our patients are asking us for help in a video visit, they're mostly going to be sitting up in front of their laptop or phone, but it's reasonable for us to ask them to lie flat, just like we would in the office. And one of the things that we'll notice is that if they seem to guard themselves to lie flat, if they are hesitant, like this partner of mine is, to lay on their back, that might give us information about how acutely any process in their abdomen is tickling their peritoneum. Okay, we've wrestled my partner back into position, and we've seen that she can move without apparently having peritoneal signs or guarding. Even now, having hands on our patient isn't the most important part of the physical exam. It's still visual. And so we can see that this particular patient isn't jaundiced, appears to be well hydrated, seems to be relatively friendly. We see that she's not got bulging flanks, that there's no caput medusa, that there isn't obvious masses. And those are things that we'd all see if someone had an abdominal process that was somewhat well evolved. Well evolved enough that we probably would have already known about it based solely on the history. But if we had an acute problem, get back down. If we had an acute problem, we might then ask the patient, hey, to stop wiggling quite so much. And then facilitate the examination with the patient's friend or family member who might be in the room. Now, if they're by themselves, maybe they're holding the camera as a selfie, but preferably we would have the patient being lying down and the camera in the position I'm at, mimicking that which we'd see in the examination room.
Okay.
All right, once the patient is lying down, it's reasonable to ask your facilitator to check them for ripeness in the same way that the patient might if they were buying a melon at the store, by putting their hand, hey, sweetie, putting their hand on the belly and thumping it. We can get an idea if they're solid or not beneath the fingers. This will take a little bit of explaining as you work with the facilitator. And we're not asking for precision here. We're asking, is there a change in tone? And you can use that change in tone to decide if there's fluid or perhaps a mass that you don't expect. More than that, though, when we cause a percussive strike, hey, like this, in the belly, I'm irritating peritoneum at a specific place in a way that I can't if I use my fingers for palpation. That causes a big concavity, a big depression. Whereas the Rovsing's test, which is to push in one spot and see if pain is transmitted elsewhere, is perfectly done through percussion and can give you a more exact localization of where any peritoneal inflammation might be. You might easily check for peritoneal irritation on a video visit without having anybody push on the patient's stomach. Depending on the patient's age, they might hop or walk up on their heels and then come down hard, all in an attempt to jostle their intra-abdominal contents. If they've got something peritoneal, they'll say, "Oh, that hurts." It's still more important to guide your physical examination and your differential diagnosis on the history that a patient gives you than anything that you see in the physical, though. And I'd like you in particular to consider that if your patient happens to be female, there's only going to be about 3 things that are quickly moving and serious that cause hypogastric abdominal pelvic pain in a woman. And that would be appendicitis, localizing to the right lower quadrant, a malpositioned pregnancy, which you could probably guess by history, or an ovarian cyst. And if a patient hasn't got one of those 3 things, you're going to be able to work them up slowly over time using your usual outpatient processes. There's a couple other physical examination maneuvers that you might be able to perform in a video visit even without facilitation. If you're not sure whether or not a patient's pain might be originating from a pulled muscle or something on the abdominal wall, you can do the Carnett sign, in which the patient lies back but keeps their head up off the surface, thereby flexing the belly wall. If they can't recreate tenderness through a flexed abdominal wall, that belly wall will have been protecting the internal organs, and we know it's deep. But if flexing the abdominal wall increases the tenderness, we know that it's a superficial process. There's another way to see if some of their discomfort might be retroperitoneal or quite deep. And that is kind of like a yoga test. We'd have somebody pull their leg up and pull it against the outstretched arm, forcing the psoas to contract. Sometimes there's a retroperitoneal appendix, a kidney problem, or an ovarian problem that'll cause deep inflammation that you might find on that psoas sign. I think the most important thing to think about when you're considering your patient in a video visit is whether or not that video visit is the right care environment for them in the first place. If, for instance, you think a patient might have appendicitis, an ovarian or tubal pregnancy, or an ovarian cyst, then right away you should say, "Oh gosh, I'm sorry, but I think we should terminate this call and instead have you come in, either to the clinic or the emergency department, as might be prudent." So that differential diagnosis that you generated in listening to the history is going to guide how much of the rest of the visit you even tolerate